very much. I realize my name is not easy to pronounce. So, I'm LYNNE HINTERBUCHNER, and I'll be talking to you today about optimizing the contrast use in the cath lab. But to get started, you all just got back from lunch, you're all kind of tired. Let's see if everybody's with me here. Scan the code up there and let's do a little bit of a questionnaire here. What is your primary role in the cath lab? This will help me in identifying how important contrast use is to you in your profession while working in the cath lab. So download that. You'll come to a questionnaire. And let's see who's in the audience today. As you can see, you can use whatever language you want. You guys get it? Oh, we got a radiographer. There's only one radiographer. There must be more. Nurses, techs, CVT, yeah. Anybody else? Technologist. So you can see we all have different roles in the cath lab. So how important is it to monitor your patients and monitor the risk? You can see there's quite a bunch. The nurses are progressing as the largest group within the audience. Oop, now it's the CVTs. So you see there's quite a lot of roles, professional roles, of people working in the cath lab. And that's why you have the lovely name of CVPs here at this conference. So let's get started here. I have no conflicts of interest. I have no stock or any financial gains by any of the contrast companies that are out there. There's quite a few. So what are the objectives today? We all know that we use the contrast in the cath lab. It's a reason we need to use it is because X-ray just isn't enough. You need the contrast to visualize your coronary arteries, the anatomy and physiology of what's happening within and how the circulation is going or not working in the coronary arteries. So what is contrast medium? We know it's that sticky stuff that gets stuck on everything if it leaks out of the syringe or a bottle drops on the ground. But we need it because you can't identify the good anatomy from the blockages, the lesions within the blood vessels. So we need to be able to see what we're doing to be able to treat appropriately in the vessels. So you really need the contrast. So it's essential for visualizing, seeing if there's blood clots. Is it calcified? Where are the bifurcations? You only can do that when you're using contrast within the arteries. But please be aware that there are adverse events that can happen. There's from medium to low risk, high risk problems that can happen from injury to the kidneys or anaphylaxis, which I'm not going to talk about anaphylaxis today. So most of the agents we're using today are iodine-based. They're radiopaque. That means that they block the X-ray signals. And it's the most common type of contrast we're using today in the cath lab. And the types we use depend on the osmolarity, the viscosity, and the sodium content within the medium. In the old days, so when I started in the cath lab, which was a very long time ago, we used the high osmolar. They were not tolerated well by the patients in the cath lab. They are used in other areas of radiology, but in the cath lab they were not tolerated well, and you had more adverse events. So they tended and very happily moved away from those, and newer agents were developed in the 80s and 90s, the low osmolar, and they're much better tolerated. They're what's the standard use in the cath labs today, and you have lower rates of adverse events. So we have the iodinated contrast agents. These are the agents that have iodine in them. They're all different in the chemical structure according to the iodine concentrations, the osmolality, and the viscosity. Don't worry, you're not going to be tested on which ones have what, but in the EAPCI PCR book, there's a nice table that tells you all of the ingredients, so to say, that are in each of the different contrast medium. You can see there's a lot out there. If you work in one cath lab, they might be using one agent as opposed to another one. So why are we concerned? Because when you use contrast, there's risks to using it. What's the risk that we all worry about is contrast-induced nephropathy. I'm thinking in German and can't say it. Anyways, let's just call it kidney injury for the sake of ease. So I'm going to go past this question because for the sake of time. If you think about what the kidneys have to do to digest, to filter the contrast. You've got the vascular side, and you've got all that blood coming through the kidneys, going into the filter, so into the tubes, okay? If you think about that heavy, sticky stuff that we see on the countertops, imagine what it's doing inside your kidneys. It's wreaking havoc, okay? So why are we concerned? And how do we know what's really happening? Well, it's really poorly understood, because most of the studies that have been done are on animals and in vitro. So we really don't know what the exact cause or why injury happens to the kidneys. What you can say is that there seems to be an interplay between several mechanisms that contribute to the injury from contrast. So why should we be worried about it? Why should we be thinking about this in our cath labs? Well, there's a growing number of procedures. We all know we're stressed out. There's so many procedures happen in the cath lab, and they just become more and more difficult. There's a lot of kidney disease, and why? Because the patients are older, and a lot of comorbidities, again, because our population is aging. So, risk of kidney injury is something we need to be aware of in patients with pre-existing renal impairment. Those are the ones that are going to be more at risk of having injury to their kidneys. Do you look at, I hope so, the creatinine level and the filtration rate of your patients when they come into the cath lab? You should really look at these, because the patients that have a high creatinine or a low filtration rate, they're going to be more at risk to develop injury. Again, age. And why does age cause a problem? If you think about it, an 80-year-old kidneys is not filtering as well as a 60-year-old's kidneys. So when you go and put contrast into their circulation, they are going to have problems just because their kidneys cannot handle it. Diabetes, we all see diabetes in the cardiac risk category is always a problem. But for renal injury, it's more so a problem if they have known renal dysfunction. So if there's a diabetic that you get that has good renal function, they don't have as high a risk as if somebody with diabetes and already impaired kidneys. So we really need to look closely of what other factors can cause problems or for us to see that a patient might have too much contrast and then have injury. So just if you look around the wheel here, the additional risk is obviously congestive heart failure, anemia, reduced volume, so those patients that are coming in with low blood pressures. So what are we going to do about it? What can we see? One thing that you should see, kind of like the emergency ambulance, doo-dah, doo-dah, watch out, this patient's had a stage procedure. So they were in yesterday or the day before, and they already received quite a load of contrast. And they're in today for that second part of the stage procedure. They're somebody that should be really watched because of the high cumulative dose of the contrast. If they've had a CT scan or an MRI with contrast, it's not so much to worry about, because venous introduced contrast as opposed to arterial is not as much of a problem. So when you're giving an arterial through the femoral artery, this seems to cause more problems. Definitions, as usual, there's a million different definitions of what acute injury to the kidney is. This is the one that's most used. Let me break that down for you. It's an unexplained decline in renal function, and you usually can define it as one or the other, an absolute increase of 0.5 per deciliter in the serum creatinine, so you're looking at the creatinine, or an increase of at least 25% of the baseline value the patient had when they came to you. But remember, when you're looking at the serum creatinine, that takes a while to change. It's the filtration rate that's really important, so make sure you're taking a look at the patient's filtration rate. So, what happens? There's a rise within the first 24 hours, so you're looking at that patient's lab values, and it's associated with the creatinine clearance, so you're looking at the filtering ability. And a lot of us don't see, because the patients are leaving the hospital quicker today, you'll see a peak at 3 to 4 days. They're often gone home already, so you don't know how much trouble they're coming into, because we're usually not measuring it anymore because they've gone home. The overall incidence of injury is 3% in the general population, but those patients with multiple risk factors, it's up to 50%. So those patients that are high or medium risk, we may want to be thinking about monitoring their creatinine levels or filtration levels when they get home, maybe send them to a general practitioner, et cetera, to make sure they don't run into trouble. So why is this important? Why are we worried about it? Because contrast-induced injury is becoming an increasingly important issue in cardiovascular medicine, and it's the third most common cause of hospital-acquired renal failure, and it increases both long and short-term risk for adverse events. Which patients are we seeing this mostly in? Of course, it's not rocket scientists, it's the PCIs, it's the interventions, because you need more contrast for these. So when you're in an interventional situation, you really need to watch how much contrast you're using. Again, look at the risks. What can we do? Which patients should we be aware of? One's coming from the emergency rooms, as we were talking this morning about STEMIs. STEMIs are a go-to to think, uh-oh, they're gonna have some injury. They're hypovolemic because of cardiogenic shock. They're hypotensive. These are the ones that are worrying about. You have the non-modifiable and the modifiable reasons. The modifiable, try and see if you can help replace fluids, et cetera, to make sure that they don't run into trouble. Also, procedure-related factors, and the big thing that we all can do something about without asking a doctor or anything else is watching the volume. The contrast volume is the biggest saver to prevent injury. There are risk score systems. You don't want to get too complicated about it, sit there with the computer and figure it out, but be aware that hypotension, patient with a balloon pump, heart failure, above 75, that's pretty old when you think about it. Back in my day, 75 was like, wow, they're old. They're kind of young these days, but 75, their kidneys are already starting to filter at a lesser capacity. Anemia and diabetes. So if you see any of these on a patient's chart in their history, be aware that these ones, you really need to watch the dose and their creatinine levels. So prevention is the key. Monitor those patients that have renal dysfunction that are diabetic. If they're first stage procedure, make sure you're checking their contrast a couple days out. And any patients with nephrotoxic drugs, they should be getting held and monitored after the procedure. How can we help within our angiography skills? Make sure you get better engagement, using a large enough catheter for the dye so that when you are taking your pictures and your projections that you don't have to do it twice. Then you can also save contrast. And also, you don't really think about this, but injecting during the Valsalva maneuver and using a power injector, which I'll talk about in a moment. And don't forget warming the contrast. It's less viscous, provides better patient comfort, and the flow of the contrast within the catheter is better. So make sure you warm.
1.5 minutes left.
Yep, I have actually 5 more minutes. It's a 15 minutes supposed to be. You're supposed to pick that. Anyways, prevention is key. Make sure you are hydrating the patient and limiting the volume of what is being put into the patient. These are 2 things we can do tomorrow. We don't need to look at papers or change anything. These are easy things to take care of right away. A quick, take your phones again, into this to see if we've got any information that's retained in our brain cells even after lunch. Rank the factors in order of the importance of preventing injury to the kidneys. Is it hydration, monitoring the renal function, contrast-induced, or the timing of contrast administration? I can give you a hint. Oh, very good. Some people were paying attention. Excellent. Type of contrast used. More important is how much is used. Renal function, you should be monitoring that for sure. Certainly the day before, but also afterwards to see if the people, because some of them don't peak for a couple days afterwards. And thanks everybody for participating. Above, you can see that some of these, if somebody does have injury and you're trying to prevent the injury, some of these up here above on the top level have not enough have enough data to say, yes, it helps, but that's not quite supporting. Below is things that we should not be doing. So these agents should not be used to prevent injury. There's not enough evidence out there saying it works. So key is fluid. If you're looking for a formula, it's a milliliter per kilogram over 12 hours before and at least 24 hours afterwards. Medications, metformin for people with a filtration rate below 30 should have it held. Your NSAIDs and your ACE and ARBs also, if they're higher risk, should be held, and also not given for 1 to 3 days after according to their renal functions. Automatic injectors, the evidence out there is just yes, no. So there's no definable evidence to say, yes, go out and buy one for your cath lab, because some studies say it does help keep the dose low, and others say there is no difference. So that's up to you to decide. The thing we can do is maximum contrast dose calculation before you start your procedure so that everybody knows in the room when you need to stop. Part of your checklist, this is a sample of one. You can see here on the left-hand side, they have the creatinine level listed, but they're not telling you what the maximum dose should be, okay, what level you can get to. And at the end, again, they talk about how much contrast was given, but it doesn't tell you what the maximum dose was. So you can't really see what risk the patient is at. So this is the dose calculation. How do you do that? Weight of the patient times 5 divided by the creatinine level, 1.2. It says 283 milliliters. You should not go above this. So when you're getting close to it, you should say, hey doc, we're getting close to the level. Do you think we should stop? This is mostly what you do in a CTO because that's where the contrast is really flying. Maximum limit for every patient should be, is 300 milliliters. So hopefully you've gained the knowledge today to make sure you're screening for risk before the procedure starts and monitor after the procedure. So if you have a patient that is moderate to high risk of having injury, make sure you're still monitoring them after the case, 3 to 4 days out. Increase hydration, give them those fluids, better to give them than not. Reduce the contrast use. And last but not least, include your maximum dose in the timeout before you start your case. Make sure everybody in the room knows when to stop. Thank you.